in the courtroom now. Good morning, everyone. How's everyone doing? Good. At the end of the day yesterday, Dr. Gurr was testifying. Dr. Gurr, I remind you that you're still under oath, and Mr. King, you may resume your direct examination of Dr. Gurr.
Thank you, Your Honor. Good morning, Doctor.
Good morning. Good morning.
Ma'am, can I have that last slide that we were working on when we ended, which was page 87 of the diagnostic manual? Doctor, when we ended up, we were talking about delusions, and we were talking about the three different common features, or the four different common features of schizophrenia spectrum disorders. And before we continue, when we go through and we describe these various features that apply to schizophrenia, and you testify about schizophrenia, do they also apply to schizoaffective disorder, which is was the diagnosis of Doctors Woodcock and Metzner in this case?
Yes, the differentiation between schizophrenia and schizoaffective disorder relies primarily on more frequent and more significant mood features, abnormal mood features in schizoaffective disorder, most commonly depression. But it does not mean, so it's a question of degree. And at times people can be diagnosed depending on the context and the time in their life as schizophrenia, and then mood features might become more common. Many times the two disorders are combined because it can be quite blurry, the difference between them.
Okay, thank you. Ma'am, can we please call out the first paragraph of delusions there? Now, are delusions come in all different shapes and sizes? Are there all different kinds of delusions that are specific to the individual?
Yes. So common are persecutory delusions, where a person believes that they are being followed or planned against, or some forces outside are operating against them. Most commonly in this country, it's going to be the FBI, the CIA, or somebody in authority that is against the person. And these are become firm beliefs that the person feels that they need to protect themselves against them. So there's, in order to be safe, this type of delusions can be perceived as being life-threatening.
Are there also referential delusions?
Referential delusion is that insignificant comments or events that happen that has nothing to do with the person have a special meaning to them. So, for example, it will be that if in the news, listening to the evening news, there's the anchor man or anchor woman addressed in a special way, this might be a code for the person that something is about to happen. So it can be related to the voice of the person on television, the fact maybe that they have now dressed in black or in white, and it can be also, so this is just one example, it can be people around them. So they can be on a bus or in a common place, school, and they believe that the way people are walking by them or turning their head does have a special meaning as in is personally related to them. So if somebody with anybody next to them would have not attribute any significance to that, but they will attribute that this is something that is related to me and I should watch out for. Delusions are in a negative, anxiety-provoking context. Another one is somatic, where a person believes that parts of their body are diseased and there is no medical explanation to that. So it can be a person that believes that I give you examples of that I've encountered, a young person who believes that there's something wrong with his knee and sees one orthopedic doctor after another, undergoes multiple x-rays and MRI, his knee is perfectly fine, and he believes that he's getting special sensation in his knee that warn him against walking or climbing stairs, and he resorts to elevators, and it becomes a very important part of his life. So it can be as simple as a knee, but it can also be related to my nose is becoming different and is changing any body part and any organ system where there is no medical explanation for it. That will be a somatic delusion. And a religious delusion is going to be one that is out of the ordinary for the person's family or community. So religion is an important part of many people's life, and it is not a delusion. But when it is outside the realm of what others expect, such as that God is sending special messages to me so that I can be the one, I'm the one who is chosen and is going to lead my congregation in a certain way, and we need to pray in a certain way, it becomes a delusion, a religious delusions.
Now it sounds like some of these delusions that you're describing incorporate aspects of daily life, kind of. Is it fairly common for folks to incorporate aspects of religion or philosophy or other areas of daily living into their delusional construct, that they become delusions over time?
Yes. So most common delusions that I've gone over and provided examples are common events in people's life that sort of gradually go out of proportion and become very prominent. Some delusions can be bizarre to the extent that they are very unusual, and most professionals have never heard something like that before. They're very unique. They're out there, and it takes a time, to understand that they are out of what most people who experience delusion, with schizophrenia or serious psychotic disorder, but these are the more extreme or bizarre.
Okay. And nihilistic delusions, would that be kind of incorporating more of a philosophical?
More of a philosophical, more of an explanation of the way the universe or the world works, the more of that the world is coming to an end, not necessarily but by a catastrophic event, but by the forces of nature, and that's the way it is, and that's the way it will always be, and interpreting the meaning of life with view that the world is coming to an end.
Now, did you opine in your reports, and is it your opinion that Mr. Holmes' delusions, referencing the human capital and the kind of the meaninglessness of life, have a nihilistic flavor to them?
Yes, and this is something that he detailed, described, and also in his writing, that the world is coming to an end, and life equals death, and the world we might have existed before we were born, and there's no point in life because life equals death. All of us are bound to die, and the way we live is really almost immaterial because death is upon us.
And is it your opinion that those thoughts reached delusional proportions in Mr. Holmes' mind?
Gradually, over time, they did, and they became the major preoccupation and force in his life.
Now, you talked about bizarre delusions. Did Mr. Holmes' delusions have a bizarre quality to them in some aspects?
They did have a bizarre quality to them. I've never, over the years, in the many people I've seen who have been delusional, what they presented were the more common delusions that I enumerated. The FBI is after them, the CIA is after them. This is very common. The symbols that he has presented in his writing and he described, I've never seen before. They did have a bizarre and pervasive nature to it in the sense that he was building upon it. It's one step after another, and you can see how the delusion builds. Having some premises that are totally irrational and that nobody in our society shares take a life of their own. And one thing, and his premise is unshaken. He still believes this way today. So these are very pervasive delusions that are bizarre. And in some way, may
Go
I
ahead.
say, in some way, over the years when I think about it, thinking about it is that the higher functioning people, namely those who have greater intellectual capacity, are the ones who come up with the most bizarre delusions.
And why is that? Why does
Well-
intelligence seem to foster these more bizarre delusions?
More elaborate thinking, more pondering about the nature of the universe that most of us just don't think about. So most people who develop schizophrenia are people like us. Sometimes I think they could have been our children or our siblings. 1% of the population worldwide. And there are people that, they're common people. Those who are with high intelligence, when they develop the delusions, they become very elaborate. The only person one person that I've evaluated the writing, most people do not produce extensive writing, was Ted Kaczynski with his bizarre delusions, who had a similar level of intellectual functioning to Mr. Holmes, IQ that are very high. So
Overruled.
It takes a certain level of intellectual ability to elaborate and take off and persist with it in a way that permeates a person's life. So it's just greater capacity that rather than being directed to what we consider productive life is invested in elaboration and explanation of everything that is around us within the delusion. So it's breaking from reality. We know the difference between life and death, but in life equals death. And as a baseline of a delusion that everything else relates to it and makes life have no meaning anymore, that's most people do not think this way, and even people who are psychotic and delusional. It takes a level of philosophical thinking and reading as well.
Thank you. Now we've been through, you can take that down, ma'am, I'm sorry. We've been through, excuse me, 2 of the 5 domains that are present in schizophrenia spectrum disorders, that being hallucinations and delusions. Is the 3rd domain disorganized thinking or speech?
Yes.
And what is that, briefly?
Commonly when we talk, people express their thoughts in talking, in speech, and in writing. At times, people who have schizophrenia, when they talk and you listen to them, are they speaking English? Yes. Are they formulating the words? Yes. And then at the end of the sentence, you say, what were they saying? How did the beginning of the sentence connect to the end of the sentence? and you're wondering, and you say, can you say it again? So their thoughts are disorganized. They do not have the same structure and ability to communicate clearly in language the way they're thinking. So it can be that what is called that they derail. They start with one topic and move to another topic. So for example, it can be, I was planning on taking the kids to the zoo. It rained. They did not predict rain today. The buses are stopping. Everybody is now coming to the station. And if you go to them and you say, how did the buses come to it? When you're on the bus, when you were going, when it was raining, they can't explain to you exactly how the bus, you cannot follow the line of thinking they were presenting to you. Or another example can be, I was reading the book and I started with the first paragraph. Everything is black around me. Black is in the print. Why do the print in black? Red is an awesome color. That's disorganized thinking. It goes from one topic to another, and color derails them, takes them off. And the listener, he will say, how did they talk like that? What they were trying to do? What are they trying to say? And when you listen to somebody like that, you have to bring them back. You say, you started this way. What were you trying to tell me? And you see it in people, in a severe form of psychosis. In writing, which is also an expression of thought, and some people with schizophrenia, especially those who are higher functioning, write and create symbols or philosophical ideas are expressed in writing and less verbally, because it's harder for them to talk. And many times they're loners and they don't talk about it. They guard against it. When you read it, you go over and it doesn't make sense to you. You say, how did they get from this beginning paragraph or this line to the other? I don't follow. Most people don't follow. So there's nothing that is wrong with the reader's ability, but it's rather a reflection that the person cannot express their thoughts in an organized, normative. Everything that we build about abnormal or schizophrenia is in relationship to most people at current society, at the current group, at the current neighborhood. It's an aberrant, abnormal behavior in relationship to what is the expected from people of that background and that age.
Now, did you, with regard to that, what you expect from people, from their background and their age, do you recall in your review of the materials in this case whether or not you reviewed a videotape of Mr. Holmes in the police department interview room immediately following his arrest for a considerable period of time, that the night after the shooting on July 20th, 2012? Did you review that?
Yes, I did.
Did you find in that videotape evidence of disorganized thinking or behavior?
His behavior, I'm trying to visualize it. It's easier for me. He was sitting in the cell facing that direction. That was the desk next to him. And he was looking under, picking from the floor. And he had on his hands, he had bags, brown bags, and he was moving the bags as if he was popping. This is not purposeful behavior. It's bizarre behavior. I've watched other inmates in cells, and it's not common. Most people are just sit quietly.
Is that commensurate with what you would expect as a psychiatrist from someone who is in their 20s, has superior intelligence, and is a graduate student in neurology to behave in that fashion?
No. It was somewhat, with the, like popcorn, looked like very childish. as if they're popping something, very childish type of behavior.
Now,
No.
did you talked about writings, and did you review the writings that Mr. Holmes made, both in the notebook before the crime and the writings from the jail afterwards?
Yes, I did.
And did you opine in your reports that you found in those writings evidence of both delusions and disorganized thinking?
Yes, I did.
Your Honor, may I approach one of the exhibits?
Yes.
And may I, this is DTR 94. May I approach the witness, Your Honor?
Okay.
Ma'am, I'm handing you what's been previously marked as DTR 94. Do you recognize that as some of Mr. Holmes' writings?
Yes,
Are those the writings that you reviewed from when he was in the jail following his arrest?
yes,
And are those the writings that you were talking about in your report as evidence of delusions, along with the notebook, as evidence of delusions and disorganized thinking?
yes,
Did they help form the basis for your opinion?
yes, they did.
Judge, I would move the admission of DTR 94. Is it 94, Doctor?
Yes, it is 94.
Yes, it is.
Pursuant to Rule 703.
703, Your Honor.
Is there any objection? Yes. right, the exhibit is admitted.
And we will ask to publish that exhibit to the jury at a later time, Your Honor.
Okay. And members of the jury, you'll recall this is one that I deferred ruling on yesterday. So my ruling is that it is admitted over objection at this time. All right, you may proceed.
So, ma'am, we've been through disorganized thinking and behavior now, and I think that we are down to negative symptoms. What are negative symptoms as opposed to these? Are the symptoms we've been through so far classified as positive symptoms in the nomenclature?
Correct.
And are those more psychotic features, or what's the difference between negative and positive symptoms?
So positive symptoms are presentations of behaviors that are uncommon and are not considered normal. So these are behaviors that in a normal, healthy person should not be there. Negative symptoms as a class are behaviors that are expected to be an integral part of a healthy person and are lacking in a person with the illness. So positive behaviors that you do not want to see are not normal, and negative are the lack of behaviors that are normative and are important for healthy functioning.
Does that include things like asociality, not socializing with other people, or being
Yeah, so it includes lack of socialization, and it looks lack of a logical type of initiation, integration with others and with tasks. It includes lack of enjoyment from life, from activities.
Does it include lack of motivation to
Lack
do
of
things
motivation,
which in the past...
yes. Or anhedonia.
Ma'am?
Yeah.
We can't talk over each
Okay.
other, okay? This gentleman over here has to take down every word that's being said. So
Okay.
it's my mistake, and I apologize. I don't mean to talk over you, but we're really going to have to try to focus on that, okay? So are there, my question was, is it a negative symptom also that someone may lack motivation in activities or pursuits that previously they had been motivated and interested in doing?
Yes.
Okay, and what's that called? Is there a word for that?
For lack of motivated behavior?
Yes.
Is it lack of motivation, unmotivated behavior?
Okay. How about, you said lack of ability to find pleasure in things that other
Or
people find
anhedonia,
pleasure?
or anhedonia. Mhm.
Other negative symptoms that you can think of, or does that pretty much cover it?
That's pretty much covers
Is
it.
it your opinion that Mr. Holmes demonstrated negative symptoms throughout the course of his life? And if so, when?
The negative symptom that he demonstrated early in his life is restricted emotions and less of social interactions. But this by itself will not define somebody as having schizophrenia. You look for constellation of symptoms. There can be many people who are not, we vary in our ability to express emotions. Some people are more quiet and they don't laugh easily and show facial expression. And it's more common in men than in women. That doesn't mean that somebody does have schizophrenia. But the degree of it in combination with other symptoms is part of the diagnosis.
Okay. Did Mr. Holmes' negative symptoms come first, or did the positive symptoms come first, in your opinion?
At times it is difficult to differentiate because in the literature on schizophrenia, most of the attention earlier on was on positive symptoms. Positive symptoms are easier to pick up. I mean, you see somebody, I bet it happens in the Denver area too, who is walking down the street and talking to himself, and you said, this is something is wrong. Or is somebody that I can't follow what they say, something is wrong. The negative symptoms can be more subtle, and only in the past probably a couple of decades, there's been more attention and more research, more efforts done to systematically evaluate them. Mr. Holmes exhibited both of them. The lack of social engagement and restricted affect were there before. The anhedonia, lack of motivation for graduate school, emerged later. The positive symptoms, the delusions, emerged later. So they were both together with some negative features earlier on, and then other negative features and the positive features emerging and coexisting, which is common.
What is a prodromal period?
I mentioned yesterday that a lot of the focus in medicine in general is shifted toward early identification of a disorder in order to prevent progression and consequences. I gave the example of a heart disease. You want to diagnose before somebody has a heart attack to prevent it. The same effort has been happening now well over a decade in the study of schizophrenia. So the focus has been of identifying early signs before somebody meets full criteria for schizophrenia as detailed in the Diagnostic and Statistical Manual. So the prodromal is a period that can last months to years where features, subthreshold features of psychosis can be observed and notable to those who are skilled. Most people will not be able to pick it up. They're just subtle changes in behavior that on further examination are consistent with an ongoing psychotic process that is just at the beginning. I gave the example of the train. The train is just beginning to show early sign that something is wrong. So that's the prodromal phase of illness.
Okay. Can I have slide 2, ma'am? In the slides that you created, is this intended to address that issue of early identification?
Yeah.
And can you, what's this slide about?
Okay, so when people do present early with psychotic features, there are a combination of symptoms that go along. It never happens that somebody will present with psychosis. I mean, they went to bed Monday night after the Eagles lost or the Broncos lost, and they wake up Tuesday morning so upset that they're psychotic. It doesn't happen. The brain doesn't work like that. So when they present, what we see is a mixture of symptoms with high level of anxiety, with emotional experiences that are different and common than what is healthy. And it can be increased sensitivity, being overwhelmed with emotions, or shutting down and being more flat. They might have cognitive problems, difficulty concentrating, difficulty in maintaining in school or at work the type of activity that before they did very easily, moving from one thing to another, sequentially, one step after another, problem solving, attention, learning, reading material and being able to incorporate it and then use it easily. At times, nowadays, drug and alcohol are an important part of it. of the presentation. So young people, I'm talking now adolescents, mid-adolescents, late teens, early 20s, is when schizophrenia emerges. So within this about decade, age 15 to 25, many young people use substance. All of this happens together with depression that relates to lack of motivation, not contacting friends, withdrawing from family's activity, feeling low visibly, many times to parents, and at times, if there are friends, to friends. This is a mixture of multiple areas that are significant. It's not like mild, can be significant and interactive. So when the person is presenting, it is not just psychosis. You have to look at multiple areas, multiple domains of behavior that are important for us, for healthy functioning, that are affected. And at times, even professionals can miss it. So most of the young people we see in our specialty program are treated for depression because this is so common in adolescents and are treated with antidepressant. And by following observation carefully, seeing them regularly, they disclose some psychotic features. And this is sort of the wreck that I refer to. When the train is beginning to derail, it's a turmoil. It's not something that, oh, everything is okay and I'll just... No, it's a real, it's almost... I work on it when working with patients. It's like an earthquake that they feel. That the regular, the familiar way that they think and live is shaking under them. And that's what the family, the parents experience. Nothing is usual and normal anymore. Something is profoundly different. But slowly, slowly, almost like a tornado coming. And it might hit at the end, but how it accumulates and wanders and gains power, it's similar to that type of presentation if I think of how to convey it.
Okay, ma'am. Now, does drugs and alcohol play any significant role in this case? Is there any indication?
Not at all.
Ma'am, we can't talk over each other. I'm
I'm sorry.
but we're doing it again. We really have to like not talk over each other, okay? And I'm sorry that I keep doing that, but just if you could just listen to the questions and then give your answer, please. Is there any evidence that Mr. Holmes was abusing drugs or alcohol and that played a role in his case?
No, there is not.
Okay, you can take that down, ma'am. I want to talk to you a little bit about your involvement in this case and how that came to take place, okay?
Yes.
And then I would like to talk to you a little bit about some other aspects. You talked about neurocognitive problems that can develop in schizophrenia and other issues like that. First of all, when were you first contacted about this case, or by whom were you first contacted? Was it from one of us that contacted you?
Yes, I was contacted by the defense team in November of 2012.
Okay. And did you eventually agree to work on this case?
Yes, I did.
Why did you make that decision?
The defense team provided me with preliminary information that was based on what they've collected, and I could also briefly look at the report that Mr. Holmes, the notebook that Mr. Holmes has produced and mailed to Dr. Fenton. And based on that information, I considered that among the possible, in the differential diagnosis, a psychotic disorder might be there.
And so did you think then that your particular area of expertise may be useful in that context to convey information to the court or to the jury?
Yes.
Sustained.
Did you think that it would be relevant to your area of expertise?
Yeah, I thought that most, as I said yesterday, that most of the people I see who have evaluated and have done research throughout over past 30 years do have schizophrenia.
Sustained.
Ma'am, did you, was some of the things that you saw consistent with much of your experience in the area of schizophrenia or not?
Yes, and I felt that I have the expertise to evaluate him.
Now, in this case, this is a criminal case, is it not?
Yes, it is.
How is the evaluation that you would conduct different in a criminal case, that you've worked on a few, than what you would normally do in a clinical setting?
Some principles of getting all the information available and repeating the evaluation over time to look for consistency and all the data that is available through interviews, through reports, through interviewing family members are consistent. This is good practice for obtaining information. What is different in a clinical setting for me is, or what you asked, is that in a clinical setting you form a therapeutic relationship with a patient and a family most of the time, and it is an ongoing relationship that I am this person's doctor. I'm the liaison. They can call me. I schedule meetings according to the patient's need. Mr. Holmes is not my patient. I was asked specifically to evaluate, render my professional opinion about his diagnosis and his mental state at the time of the commission of the crime. This was explained to him, and I followed the rules of what is expected in obtaining information and review and producing reports in a forensic or a court setting. It's this is totally different than a therapeutic relationship that I have with a patient. He's not my patient.
Okay. In this case, did you review a tremendous amount of information that was provided to you? And we'll go through some of that in some detail, but police reports, interviews, photographs, videotapes, 100,000 pages of information or so. Is that fair to say?
Correct. I reviewed all the information that was provided to me, which was voluminous and was produced, by investigators for the prosecution, for the defense, all information, knowing the source of the information. Yes.
And is that normal for you in a clinical setting to have that volume of information to review? Is that something that's different?
It's very, very different. So in a clinical setting, the interviews that we conduct with the individuals, in a clinical setting, the individual is coming in many times against his or her will. They're brought in by the parents, or the court will commit them to treatment. But they are there, and you have limitless time to interview them. If you want, it's day after day. I don't have to fly in and arrange for that or cancel because there's a snowstorm. And you obtain collateral information from the parents, who many times live with the individual. We see young people or frequently visit the individual. You have school records. We obtain as much information as we can, but it's never, in young people, fortunately, most of the people we see with schizophrenia do not commit crimes. So it's very different.
Okay, thank you. In the materials that you reviewed, did you write 3 different reports in this case?
Yeah, 3 different reports. Let me see, report. My first report was on a
Did you write 3
2013.
reports?
Do I have 3 reports? I think so. Yes, 13, 15, yes. Yes, if you refer to the third report on the MRI,
Yes.
yes. Ah, okay, yes.
Okay. Did you include in your reports a section on the materials reviewed?
Yes, I did.
Okay. Now, the materials that came into you for your review, did they all come in one big pile at the beginning of the case, or did you get a lot of materials towards the beginning of the case, but many of the materials continued to come in over time as the months and even years progressed?
Yes, the materials came in over time.
Did you review them as they came in to the best of your ability, given the fact that you have another full-time job?
Yes, I tried to review it as they came in and sequentially, so that I will have organized them by the time they came, and they always arrived in a secure mail.
Okay.
And yes,
Did you do you recall reviewing police reports in the case?
yes, I did.
A lot of them?
Yes,
Did you review every single police report? Like, for example, did you review all the medical records of the folks who were victims in this case, or was that irrelevant largely to your consideration?
I did take a look briefly at the reports on the people, on the victims, but most of the time I reviewed the reports that were pertinent to the setting, the theater, the police encounter following the arrest.
So did you review the interviews done with Mr. Holmes?
Yes,
The videotaped interview and the audio taped
Taped.
interview with Agent Gumbiner?
yes,
Did you review materials that led up to or before the shooting? For example, did you review emails that Mr. Holmes sent to his family and friends?
yes, I did.
Did you review Gmail chats between Mr. Holmes and his friends and text messages, and I'm probably getting the electronic media wrong, but Gmails, emails, chats, those types of information between Mr. Holmes and his Gargidata, for example?
Yes, I did.
How about between him and Ben Garcia?
I did.
How about between him and some of his professors, some emails?
Yes, I did.
Did you review the records from Dr. Fenton and Dr. Feinstein?
I did.
Did you find those to be significant? Were those significant in your opinion?
Yes, they were.
Did you review some of his schoolwork that he did?
Yes. Is reports from school, starting from grade school through the reports from undergraduate and graduate school.
Okay. How about his interviews that were done with classmates of his and professors at graduate school?
At graduate school and undergraduate school and teachers in California, yes, I did.
Interviews with family, friends, and neighbors and teachers from his childhood?
I did.
Did you interview his parents?
I did interview his parents.
Contained in your reports, and we may go through them a little bit, but did you list in your reports every single specific item that you reviewed, or did you just put general categories of items that you reviewed?
I put general categories, that items that I reviewed, and I did not list every item that I reviewed, what I mean is that every email that I reviewed, or every video that I reviewed, or every report. I used it general, or every medical record or jail record. I used it as a category. I had them all available.
Did you interview other folks in the case? Did you interview his sister, for example?
I did not interview his sister.
And how about Gargi Dada or Ben Garcia? Did you interview them?
No, I did not.
Did you necessary in order to render your opinion or your diagnosis in the case?
I read the interview material that they were interviewed by others, and I read the email, electronic exchanges that they had, but I did not think that, based on the information that I had, that I needed to interview them. I believe that they disclosed all the information available to them, to the investigators.
Did you know whether or not they agreed to be interviewed or not at any given time?
I know that some people were not. I remember that we spoke about it, that some people did not want to be interviewed.
Did that include Drs. Fenton and Feinstein?
Yes.
Did you talk to Dr. Metzner and Dr. Reed?
I spoke to Dr. Reed. I spent an hour. Dr. Reed requested to talk to me, and I spoke to Dr. Reed for an hour.
Okay, did you talk to Dr. Metzner?
I spoke to Dr. Metzner too.
Now, with regard to your report, do you are your reports intended to be a complete statement of everything that you think about the case, or are they intended to be a summary of your opinions?
My reports that are entitled Neuropsychiatric Evaluation Report are a summary, and they are similar to the format that we use clinically.
Okay, can you explain that, please?
So the format that we use is identifying information about the person, when it was the report was produced, what was the time of evaluation of a person, what was the purpose of it, what were materials reviewed, a summary, not detail of every record and a date, the background information that was available about the person, that includes, if it's pertinent, a medical history, if there are medical problems that existed before, non-psychiatric, I refer to medical, academic history, school performance, social history. If the person is working, it will be a vocational history. And then the psychiatric history. What type of encounters have they had in the past? If they were treated before, a history of that. And then a summary of the interview conducted with the person. So when the person was seen, as much as possible to be able to give quotation that provide a sense for what they were saying, that can be meaningful over time, and then an overall summary of the conclusion of the entire thing, a brief summary at the end.
And in addition to your reports, have you also provided all of the notes that you, from your various interviews with Mr. Holmes?
Yes, I did.
The first report that was written, was that in June of 2013?
Yeah. June 17.
Did you write that report because you wanted to, or did you write that report because you were asked to?
I was asked to write the report and wrote it all by myself.
Did you, incorporate all of the information that you had at that point, including the interviews that you'd done at that point, in your opinions contained in that report.
Correct.
Did you receive more materials after that, a considerable amount of more materials?
Yes, I did.
Did you interview Mr. Holmes more after that?
Yes, I did.
As a result, at some point, did you write another report to, I guess, be an addendum to your first report?
Yes, I did.
Was that intended to incorporate the new information and the new interviews that you've done?
Yes, it was.
And did your opinions change at all over the period of time in terms of your diagnosis or your opinion on sanity?
No, it did not.
When you wrote your first report, did you include in there that you had reviewed the medical, psychiatric, and other institutional records and portions of the discovery materials related to Mr. Holmes?
Yes.
Mr. Holmes' notebook?
Yes.
Oral accounts of interviews with family members, teachers, and students?
Yes.
And did you have at that point Dr. Robert Hanlon's first neuropsychological testing report?
Yes, I did.
When you wrote your second report, was that in 2015, February of 2015?
Yes.
Was that because you wanted to, or was that because I asked you to?
You asked me to.
Did you include in that report a list of more materials that you'd reviewed?
Yes, I did.
Arapahoe County jail records?
Yes.
Okay. Before I go on, did you write that first report before Dr. Metzner or Dr. Reed had even seen Mr. Holmes?
Yes.
Did you include in your second report that you had reviewed, you said jail records, Dr. Metzner's report at that point in time?
Yes.
Dr. Gray and Dr. Manguso's testing results?
Yes.
How about Dr. Reed's video recordings? Some 22, I think, or 23 hours of video recorded examinations that Dr. Reed did. Did you review those in their entirety?
I reviewed the 23 hours in their entirety.
How about, did you reflect in your notations there the various doctors that you talked to and the reports from the interviews, phone interviews that you reviewed?
Yes.
And did you review, at that time, include the CT scan that was done of Mr. Holmes in 2012, as well as Dr. Robert Hanlon's second neurological examination report?
Yes, I did.
Now, are your reports, you've read then the reports of Drs. Reed and Metzner. Would you agree with me or not that theirs are considerably more lengthy and detailed than yours are?
Yes, they are.
Was it your intention to write such a detailed report in this case?
No.
Did I tell you how you should write your report, or did you just do it when I asked you to do it without direction?
I did the report the way I do other reports, totally independently, and presented to you my final report without any comments, but thank you for your work.
Does the length or shortness of your reports in any way mean anything about your opinions or the firmness of your opinions or the thoroughness of the review of materials that you did?
I don't believe so.
Let's talk briefly about your contact with Mr. Holmes. Dr. Reed interviewed Mr. Holmes for 23 hours, you just said. Do you know the total amount of time that you've spent with Mr. Holmes since the beginning of this case?
I believe it was 28 hours, but if you I'd like to be always accurate, so let me look at my notes and I can tell you precisely. So I saw Mr. Holmes on December 19th, 2012, from 1:45 to 4:45, 3 hours. I saw him on February 9th, 2013, 2.5 hours in the morning, 4 hours in the afternoon. So it was a total of 2.5 hours in the morning, 2 hours in the afternoon, for a total of 4.5 hours. I saw him on May 2nd from 9 to 12 and from 1:30 to 4 in the afternoon, so it's 5.5 hours. I saw him on November 18th for 3 hours and 45 minutes, and I saw him on August 5th for 5 hours and 15 minutes, a total of 28 hours. I hope I did correctly.
Did you, is one of those visits missing from your report?
One of them, the one on November 18th, 2013. I confused it, I'm sorry, I think with the one, because I had another one on November 18th, same date, 2014. So
Did you also see him November 20th, 2014?
I saw him November 20th, correct, 2014, correct. For 6.5 hours.
So did you see him before Doctors Metzner and Reed?
Yes,
And the first time you saw him on the 19th of December, 2012, was that about a month after he was hospitalized at Denver Health Medical Center?
yes.
Let me ask you this: were you originally scheduled to come see him in November?
I was scheduled to come before, but he was hospitalized before, so it was postponed to December.
Do you know what materials you had to review prior to going in to see him that first time?
I had, I have a list of it, I can go back to it, but from what I can recall, I had information that related to some of the background of the interview with his mothers, the school records, interview with his friends and neighbors, and some of the medical records, the jail records, and some of the early discovery material that was provided to you and then to me.
Did you at that point in time have full copies of the writings of Mr. Holmes, either the notebook or the
No.
writings from the jail that we've just introduced?
No, I did not.
So did you go through those writings with him at that point in time in any detail?
No.
What was the point or your goal in that initial interview with Mr. Holmes?
In an initial interview, we're not knowing the person, hearing about him, but it's different to hear about somebody and walk into a room. Initial goal was to establish some rapport with him and evaluate, get a life timeline, what I call, and going over from early on to the time of the commission of the crime, of major life events, with the idea that he will be able, with time, to disclose more and that we can come back. So to establish a first step of getting to know him, forming some initial impressions, and for him feeling, hopefully, a little bit more comfortable with me.
Was it always your intention to go back and re-interview Mr. Holmes again, not just one more time, but several times?
I will say as many times as possible, yes.
And did you attempt to schedule that as your schedule allowed?
Yes, I did, and as the weather allowed.
prior to seeing him that day, was it significant to you in your review of Dr. Fenton's records and Dr. Feinstein that they had noted that they thought he might be experiencing psychotic level of thinking when they saw him in the spring of 2012?
Yeah, it was significant that other professionals with whom he has been in contact for the first time as a young adult were concerned about that to the point that they did, another professional, Dr. Feinstein, was called in. This is not common procedure. It happens when there's a red light in the head of a professional to call somebody else in to evaluate for risk and safety. That's when we do it, and this is the way it's commonly done when somebody else is called in. So I took it very, seriously, everything that they put down.
Okay. Did you think it was significant that Dr. Woodcock had seen Mr. Holmes just a couple of days following the shooting, a few days, and had and felt that Mr. Holmes was psychotic at the time?
Yes, it was.
And is that consistent with or not with the writings that we've just introduced? Is that evidence psychoticism to you, the writings from the jail?
Yes.
Now, when you saw him in November, you said that when you saw him in December on the 19th, you said that it was about a month before that he'd been in the hospital. Was he medicated when you saw him?
Yes, he was medicated with antipsychotic, antidepressant, yes.
And was the antipsychotic Risperdal?
Yes.
How long does Risperdal take effect to actually begin to suppress some of the psychotic symptoms?
It varies. The dose is important. The way it is administered, it was administered by mouth. And it can take days to weeks. Depends on the individuals and on the symptoms.
Okay. Did Mr. Holmes reveal to you, not on the 19th, but later in time, that he continued to experience hallucinations and other psychotic symptoms throughout the month of December following his return to the jail?
Yes, he did.
And did they then subside slowly after that period of time?
The symptoms have improved, and he attributed that to the medication. He wanted to continue on the medication.
And did some of those symptoms include seeing hallucinations of shadows?
Seeing shadows, yes.
How about, were there any audio hallucinations, voices, if you recall?
There were sounds that he heard. I wasn't sure if those sounds were part of the jail milieu or that they were unique to him. Okay, so I noted them, but it's just one aspect of the clinical presentation.
So are you saying it's possible they're just sounds that he heard in the jail? Is that what you were saying?
In the jail itself. In the hospital, he did hear voices.
Okay. How about referential thinking during that period of time? Getting special messages from the television or movie?
No.
I want to go through with you a little later some of the statements that Mr. Holmes made to you over that period of time. But was there a change in Mr. Holmes? That first time you saw him, was he different the way he presented than when you saw him years later, for example, around when Dr. Reed saw him?
Yeah, there was a significant change in his appearance. During the first interview, it was like pulling teeth. He was very quiet. He wasn't moving. There was very limited eye contact, and I tried to establish I will be quiet and will wait for him to look at me, and at times he will just continue to stare down. At times, he will look through me. You have the sensation that somebody is looking, but they're not looking at your face. They're sort of like looking through you, as if you are not there. And at times, he will look at the wall behind. There was no windows behind me. The windows were on the side where the guards were. He will look at the wall and his eyes will widen, like, and move his head back. There were no facial expression, and his words were extremely terse. I describe it as pulling teeth. Answering questions with 2 words and me asking him to elaborate and pushing from all directions. And most significant for me was the time that he did express emotions that was unusual level of expression, that where he became red in his face, and it was in the context of pushing him on. What was it like in high school? What were you afraid of? His face became red. He did not cry, but it was his lips pursed like that, and he became shaking just like that. And I've never seen him again like that. And in his follow-up evaluations with me and what I've observed from Dr. Reed, he was, his affect was restricted, but he was talking more. He was producing sentences that was very different from the initial evaluation. I had the sense that he was scared of me, which he said that he was.
Did he present very differently? I don't know if you just said this, but did he present very differently than the way he appeared in the 23 hours of videotape examination that Dr. Reed did a couple of years later?
2 years later, on medication, in the same environment, that in many ways is optimal for him, limited interactions, and going over the same things again and again. I think that all of the professionals who have seen him and reviewing the record asked him the same type of questions. So easier, my sense, than when going over it for the first time.
Harder to talk about it the first time?
Harder to talk about the first time, yes.
Now, Dr. Reed, in his report, do you recall him putting in kind of a disclaimer about the fact that his interviews took place 2 years later and Mr. Holmes was medicated, and we have to take that into consideration in evaluating those statements?
Correct. The psychotic state is a fluid state. People do not remain, some features persist, but people can change the way, sometimes in remarkable way. And medication can have, for many people, a big effect, and it had a beneficial effect for Mr. Holmes.
And do you agree with Dr. Reed? Is it your opinion that took place in this case?
Yes, I do.
Now, does that mean that he was no longer psychotic, or did the delusions persist?
The delusion persist. The level of anxiety was reduced. The level of depression was fluctuating, but overall somewhat reduced. But the delusions persisted, still persist, with not that level of intensity.
So are you saying that he still believes that human capital is the truth?
Correct.
To this day?
To this day.
Now, how about hallucinations? And the disorganized type of thinking? Would the medication help with that? Help to organize your thoughts and get rid of the hallucinations?
Antipsychotic medications were developed and work on the positive symptoms. So they decrease, in addition to decreasing anxiety that is very common in schizophrenia, they decrease hallucination, disorganization. Less likely the delusions are not affected to the same extent, and they do not impact negative symptoms. There are no medications for negative symptoms. It was hoped that some of the new medication that were called second generation might help a little, but it was not a home run. There are no good treatments for it.
So is there a cure for schizophrenia or schizoaffective disorder? I can rephrase the question, Your Honor.
Okay, go ahead.
Is Risperdal, the drug that Mr. Holmes is on, a cure for schizophrenia, or does it just reduce some of the symptoms?
It reduces some of the symptoms.
Now, in addition to the clinical presentation that you talked about, and in terms of that clinical presentation, that flatness of affect, was that significant? And we're going to talk about that in a little, what the significance of that was, but was that significant in your mind, the flatness of affect?
It was marked. It was the most, even before you talk to a person and you begin to talk to a person, you see the face. The face is how we communicate, one of the way we communicate emotion. So you look for flatness of affect in facial expression. Facial expression change with the content of what we say. You look for hand movements. People commonly move when they express emotions. And you look for the voice, the tone of voice. The tone of voice commonly fluctuates. For Mr. Holmes, the face was restricted. No matter what he spoke about, it didn't change. It was like frozen. His hands did not move, barely moved, and this was initially first interview, his hands were shackled. For the other interviews, his hands were not shackled, and it's still very limited movement over a course of 3 hours. Very unusual. People move. We all move. Very unusual, sitting like that. And his voice was, every word was slow and monotonous during the first interview.
In addition to your clinical impressions and the things that you gain from interviewing someone and watching them, do you also take into consideration, did you take into consideration possible neurocognitive deficits that might be associated with schizophrenia?
Yes.
And you indicated, I believe, that you reviewed both of the reports. At that point, the first interview, you had Dr. Hanlon's first neuropsychological evaluation at some point, and then the second time around, you had the second neuropsychological evaluation. Is that right?
Yes.
Let me just make sure that's true. Yes, when you wrote your first report, you had Dr. Hanlon's neuropsychological evaluation. Is that right?
Yes.
Can I have slide 3, please, ma'am?
Before we go to that slide, Mr. King, is it okay if we take our morning break at this time?
Absolutely.
Is that a good time? All right. Members of the jury, let's go ahead and take our morning break. Please make sure that you follow all my admonishments during the break, and I'll see you back here right around 10:30. Thank you.
Excuse me.
Please be seated, everyone. The record should reflect that the jury has exited the courtroom. Let's go ahead and take our morning break, and I'll see everyone back here in about 20. Thank you.
All rise.